Okay, I think we can go ahead and get started, and I think other people will join over the next few minutes. So thank you everyone for joining today's edition of our Ask the Expert series, where we talk to experts such as doctors, nurses, and those certified and working in the diabetes and medical space. And today I'm super excited because we have Dr. Shadi Tabba, who is an American board certified pediatric endocrinologist and certified in diabetes as well. He is working here in Dubai at the Dubai Diabetes Center. And we're so happy that he's agreed to join us today to talk a little bit about diabetes technology, what's happening in the market, what's up and coming, and different things that we should look out for. For those of you that I've not met before, my name's Pam Durant. I'm the founder and managing director of Diapoint ME, the place for diabetes. And while we serve people with diabetes in many different ways, it is no replacement for medical advice. And so we always love having these experts with these discussions to bring you more information and give you more information that you can take out and go speak with your doctors about and find, medical evidence about what's going on out there. So Dr. Shadi, thank you so much for joining us today. We're really happy that you're here.
It's great to be here. Yeah.
Thank you. And I know you have a presentation that you will go through. Is there anything you would like to say before we start off with that today?
I'd just like to say thanks to everyone for being here and listen to my humble opinions on things. Yes, it's surely not something easy to deal with, and anyone who says otherwise needs to learn more. It's difficult, and as physicians and healthcare workers, we're trying to help make it a little bit easier. And obviously, with all these devices and things coming available and coming through, all hopefully helping people, make their lives easier. So that's basically what we'll talk about, and everything we mentioned that should be ultimately our goal in discussing is, okay, how is this making things better, be it through diabetes control better or making lives easier.
Great. And two things I want to mention before we begin. If you have any questions at all during the presentation, in the bottom of your screen, there's a chat box. So please write your questions in there, and then we'll address those. And also, this will be recorded so that people that were not able to join us can listen to it again, and we'll have that up on our website so everyone can listen to it. So I'm just going to share my screen really quickly so we can start. Okay. All right, Dr. Shadi, I'll turn it over to you.
So, if we go back, let's say 15 years or 20 years, when we were just dependent on someone using a glucometer, poking their finger, getting a blood sample, and looking at a blood sugar. At the time, that was the best we had, but we had to depend on that, and we had to look at these readings we get, and keeping in mind this is only looking at a person's number at that point in time. Anything in between those blood sugar checks was just unknown, a big unknown. So one aspect of these technologies is helping us just know what's going on more frequently. And so when we've had the continuous glucose monitors coming in, the goal of that was to tell us what exactly is going on in between. And so when you just looking at this table, you can kind of tell the person on top is checking their blood sugar 6 times a day, which is relatively impressive. But if you look at the actual numbers, you see that there's hypoglycemia that was missed, which is anything below the blue range. Hyperglycemia, pretty extreme, that was also missed just because we couldn't get that information just by doing a glucometer check, even if it was that frequent. So um, this is one aspect of technologies is helping us get more information. The other aspect of it is warning us of numbers that are going into the extremes. When in the case of glucometer use, we're kind of dependent on either the person sensing it, which some people don't sense it, hypoglycemia especially, and or just coincidentally bumping into an unusual number because it happened to be a time we're checking. So from that aspect, that's been very helpful too. So it's made people's lives easier in terms of getting to know what the blood sugars are without needing to poke the finger as much, but also helping diabetes control where we're immediately finding out numbers outside range and being able to do something about it sooner. So that's in terms of CGM. Now, this variability that we're finding that's actually there, but we weren't seeing it before, is also reflected when we talk about hemoglobin A1C. So on the next slide, so you'll see with hemoglobin A1C, it's the same idea that, okay, you have different people, they have the same hemoglobin A1C, they're coming to visits, but then again, when you look at what's actually happening, when you have all the readings, continuous glucose monitoring, you can find out that, for example, the person on the green line on the graph doesn't have a lot of variability, and that's actually better. There's not a lot of high numbers and low numbers. That's more similar to physiologically what's supposed to happen, versus the person in the orange line and the black line, where there's a lot of ups and downs. The average glucose level is still something that would give a hemoglobin A1C of 7%, but there's a big difference between these people. And so part of these diabetes technologies, again, is giving us more information where we're not just looking at a few glucose numbers checked on a meter and a hemoglobin A1C, which may or may not accurately represent how capable we've been to get adequate diabetes control and preventing diabetes complications in the future. So that's the major aspect relating to what diabetes technology is doing in terms of helping diabetes control and getting more information. In addition to that, of course, if we could go to, if I could go to the next slide, there's the aspect of making people's lives easier. Now, you can build something that does an amazing job with diabetes control, but if it's not practical for a person to use it and help them even when their day-to-day life and with diabetes, then it's not going to help. So the first pump that was made almost 60 years ago, it looks like this, and that's not something practical that's going to work for someone to carry on their back all the time. So of course, as time has moved forward, things have gotten better and better, where we're now, there's a big focus on making the person's life easier, and not just helping diabetes control, but allowing that whatever was pushed forward to make a person's life easier in taking care of diabetes. So if you could go to the next slide. So in this, you know, continuum of simplifying versus making things more complex versus being more physiologic and non-physiologic, sorry, the previous slide.
Oh, sorry. Oh, wait, sorry, my bad. It went a little fast. Okay, there you go. Sorry about that.
So as time has moved forward, we've moved from the lower right side of your screen, where things may have been simple, but they're non-physiologic and weren't allowing better diabetes control, we've increased complexity with all these devices that need a lot of training and education, or even intensifying therapy with multiple daily injections and needing to count carbs and stuff. So there's been more complexity, but it's helped things become much more physiologic to help with diabetes control. Now, the hope is that now that we're over at the left side, but we're a little bit up on the complexity, that we can shift that towards the right so we can have something physiologic and more simple. So as these technologies get better and better, that will be the case. And of course, at some point in the future, if there's a cure, that'll hopefully just shift it all the way, where we have a simple physiologic way to completely get this treated. So that's the general gist of technology in general and what it's doing. So in terms of what's available right now, so I'll just talk right now, there's no slide for this. What we've got right now is in terms of sensing glucose levels. So we have continuous glucose monitoring. What's available in the UAE is either the flash glucose monitoring by Libre, and that is a sensor worn for 2 weeks that does not need calibration, so that's a positive. But on the other hand, there's no alarm system that'll alarm for highs and lows on Libre so far. Then we've got continuous glucose monitoring with alarms that will alarm for highs and lows, for example, Dexcom and Guardian, which is helpful to alarm when there's high and low. But those devices need calibration. Some people aren't as excited about that sometimes, even though it's a calibration that may be 2 or 3 times a day. But that's the other option too. Now, in terms of pumps, what's available right now, there's older versions of pumps like Roche pumps and older Medtronic pumps, and then there's the newer Medtronic 640, although I guess that's not new anymore. It's been there for about 4 years. So that's what's available here. Newer pumps may be coming up on the horizon. A newer Medtronic pump, something similar, something from Roche that's similar to the Omnipod, which is like a patch pump. Those are things that may be coming over the course of this year. We're hoping that, upcoming versions of everything will be closer to completely closing the loop. Same thing with the sensors and CGMS. What may be coming soon are versions of, for example, Dexcom, where someone doesn't need to calibrate anymore, sensors that can last longer on the body. We do have a little bit of a challenge here in UAE, that some things that have come up in other countries have not made their way here yet for different reasons. But hopefully that'll happen soon. Obviously, one of the big challenges to this is cost. And some people have been successful getting cost coverage through insurances. For others, it's been such a challenge that they've had to cover out of pocket. So that's one challenge. But we hope that over time we'd be able to get as many people as possible to use technologies that may be helpful. I'll say, at least from my practice, about 80% of people have some form of diabetes technology on them. Now, in terms of what fits for each person, the decision is usually customized. So, not every person will do well with a pump or will do well with a sensor. It's not to say that someone who's injecting insulin with pens and using a glucometer can't get decent diabetes control. It's very possible. It takes a big effort, but it's possible. And that's not to say that someone who has a pump or a sensor automatically is in great shape and having excellent A1C. So there's several factors involved in getting to the place we want to for diabetes control. And what we use would have to be kind of customized to the patient and family's needs, what they're able to deal with, what fits their life most. And that's something that really gets discussed between the patient and family and the doctor to see what is the best option open to them and trying to get the best out of it.
Great.
So
And if
that's
I
kind
can,
of
sorry, can I just interrupt you for a quick second? Because one of the questions that came up was very topical to that. And I think you just answered that. If you compare MDI, multiple daily injections, to managing with a pump and a CGM, do you think one is better than the other? And I think you've just answered that question by it depends, right?
Yeah, it depends. I mean, having some of these technologies allows for it opens up horizons that may allow for better control. It doesn't necessarily mean it'll happen. It's just that if it's done right and the person is able to adapt to this device on their body and uses it correctly and is taught well how to use it, and the child is open to using it and happy about it too, that does open avenues to obtain better control than you can get on MDI. But there's all these little ifs there that need to work out too. Because so we do have a percentage of people that do move forward and get some form of technology on them. And then shortly after they say, you know what, this is not working for us for any reason. Be it they don't like something attached to them, be it they get skin reactions, be it that some people, once they have, for example, a pump, their level of focus on what needs to be done kind of wanes a little bit, and they get a little, they're not as attentive. And so we've seen people actually not do as well when they move on to technology. So there's several things that need to be looked at to kind of see for each person whether they'll do well with it or not.
Okay. And you also mentioned the possibility of a Roche pump that might be coming. Does that work with a continuous glucose monitor as well?
No.
Okay.
So and this has just been like 2 weeks ago approved in UAE. Because Omnipod was kind of the first of the patch pumps that came out that have no tubes, we always end up kind of comparing to that. So this Roche pump called the Solo pump is kind of the equivalent of that. It's been available in Europe for almost a year now. I don't think it's in the US, but I think it's mainly in Europe, and it's finally been approved in UAE. I know there's some people that will be interested in that because of not having a tube. So it kind of simplifies the process, but it does not have an associated sensor that works with it. Okay. So if someone wants a pump and a sensor, it'll have to be like a different.
Another one. Okay.
Yeah.
Okay. And just one more question about the device names that you mentioned. When, or do we know when the Libre II would become available here?
We don't know that. I mean, we hear rumors that this should be happening soon. But, I think companies and their representatives, they're not really allowed to tell us, open up about things that may be happening soon if they're not officially approved. Right. But we hear rumors that things are moving, that maybe that'll happen soon. Dexcom G6 maybe soon. So
Mm,
I'm hoping a lot of the things we know that are available in other countries make their way here and can get started over the course of this year.
great. Yeah,
Obviously, COVID and all the drama that's happened over the last few months has delayed some things that may have happened sooner.
mm,
Yeah.
okay. All right. Excellent.
So I'm I don't want to keep rambling on too. I'd like to see if people have questions and kind of let that guide where I talk further. And if if everyone's questions are answered, I could talk some more about some specifics on technologies.
Okay. So yeah, please write your questions in the chat. And we have a couple of questions from the other day so before I get to the other question that someone sent me, I wanted to ask you, you mentioned A1C, and of course everyone is always curious about A1C. And what is the benchmark, or what is considered best practice for A1C for a person with type 1 diabetes, or for a child with type 1 diabetes, but also for an adult? Because sometimes we're not all parents on this call. We have adults with type 1 as well.
Okay. So I may have missed the first part. So the question is just about what are the benchmarks and
what is a good A1C? What is a great A1C? What is a realistic A1C? What should we be striving for?
Every year we get guidelines from the American Diabetes Association that kind of tell us what we should be aiming for, so to speak, and what should we get. Now, A1C, like I just talked about, that there's weaknesses to how well does an A1C represent someone's actual control.
Yeah, in this picture here.
So why do we continue to use it? Well, the problem is that all of the studies that have looked at probability of long-term complications from diabetes were done in relation and comparison to A1C. And so the studies that said, okay, if your A1C is above so-and-so, you have a higher chance of complications. You need to be in an A1C of so range. And so that was done way long time before CGM was an option. So we still do look at A1C. So in terms of A1C, over time, as we've had these diabetes technologies come in that have allowed a person who's really gonna try to adapt and implement these technologies in the right way, allow that person to get better hemoglobin A1C. As time has progressed in that direction, the hemoglobin A1C goals have come down. And so the most recent goals say that we'd like to keep A1C around 7 or under for adults. For kids, we've talked about being under 7.5. There used to be discussion on saying, well, if it's a very, very young kid, like under age 6 or 5, that maybe we can accept up to 8%. In the most recent guidelines, that's become not as important of an issue. So it's really, for kids, I'd say less than 7.5, and adults less than 7. It's especially with the devices that are alarming us for hypoglycemia. So the fear of hypoglycemia is not as big as it used to be, because now we can detect it earlier with using these technologies. So that's kind of where the A1C is. Now, for someone using a continuous glucose monitoring, the number we look at is something we call the time in range. So out of a person's 24 hours a day, 7 days a week, the continuous monitoring is telling us what percentage of time is this person's number within target range. And if that gets to, the target would be to get to 70% of our readings being there, maybe 25% acceptable to be high, and up to 5% or maybe even 3% may be acceptable to be on the low side without severe hypoglycemia. So time in range of 70% would be great. Most people, if they can get up to 60% or higher, for kids, that's probably pretty good without having a lot of hypoglycemia. So that's in terms of like A1C and time in range and where we try to get to.
Thank you. I'm taking notes, so I'm going to run after this call and check my son's time in range. Okay, so we have questions coming in.
Well, for what Erin uses, I don't know that data is like that. In the newer software, they're gonna add that into the download.
Okay, that's good. Oh, bummer. Okay, because I don't think it's COVID times. It wasn't probably 60%, or I'd be surprised if it was, even though we strive for that. COVID and adolescence. So Tina says, my son is 15 months old, diagnosed at 11 months. We are currently using the 640G pump with the Guardian sensor and Night Scout in order to have the alarm function. What are other pumps that are appropriate for such young children?
Well, that's at some point in the past when pumps were a new thing, and because there had not been a lot of studies that looked at pump in such a young age, they used to have put on limitations like regulatory boards and ministries of health in different countries. They used to put a limitation on age, saying, oh, if you're below a certain age, you can't have an insulin pump. Now, as people who work in the field and see this situation happening, and as parents, of course, you can absolutely see that having a pump, especially with a sensor in this age group, is actually even more important and helpful than a teenager, maybe, just because they're babies and they're eating very frequently. You can't control their food. You need to feed them frequent enough, and that if they're on injections, that means so many injections every day. They can't express how they're feeling, especially with low readings. And so it's almost like the pump sensor system was designed for a baby with diabetes, just because everything, all of these things they need to be monitored and make their lives easier is there in it. So we've had all this time where it was a challenge, but as physicians, we would do it. And even babies who were born with diabetes, there's some strange types of diabetes. I don't want to say strange, rare types of diabetes that are there at birth. We've started people on a pump at 2 days of age. So it's really good to have that. Now, in terms of what more is out there that may help you, I mean, here in the UAE, I know there's nothing more to do with this. In terms of outside UAE, the Medtronic 670 pump had some improvement in features, and especially in terms of dealing with high numbers and bringing high numbers down, not just dealing with low numbers and suspending basal for lows or before low. I would say the newer T-Slim Tandem Control IQ is really showing beautiful results in what we've heard of in studies and in conferences we attend. It's not available here, but I think that would be very helpful for someone. The nice thing about it is it's associated with and works closely with Dexcom G6. And so it works with that, and then you've got the app connectivity and the phone connectivity as part of the system. Versus now, Night Scout is great, but it's not officially part of the pump software system that they approve and use. So it's Tandem T-Slim is probably the thing out there that may be nice and helpful for you, but it's not available here.
Yeah, and that for people that consider a device that's not available here, what I can say is you just need to make sure that logistically you can get them on a regular basis when you need it. That's one big thing to consider, is if they'll ship here, or I know some people maybe have done something like a shop and ship before, but you want something reliable so that you can make sure your supplies are coming.
And once it's here, and especially planning for emergencies too, because, you know, suddenly you run out of infusion sets or sensors and you're stuck. And obviously the comfort of the physician following and helping you, their comfort dealing with it too, because if they don't know how to deal with the different, especially some of the newer pumps that are closing the loop, and how to deal with being in the loop versus getting kicked out of the loop, and what things can be adjusted for the pump. There's a comfort level that comes with experience and official training by the company producing a pump that some of us physicians may not be as comfortable with, because with something we've never experienced directly.
Yes. So next question. My daughter is 9 years old. She was diagnosed 3 months back. And my question is all CGM showing a variation, a 10 to 15 minute delay in compared to like a blood test finger prick?
There will be, with all CGM and sensors, there will be some delay, ranging from 10 to 15 minutes or so. Reason being is that the sensor is it's not actually checking blood sugar level. It's measuring an electric current between the cells of the skin that does change when glucose levels change. And so it takes time for a change in the amount of sugar in your blood to cause a change in the level of sugar between the cells of the skin, and that to cause a change in, let's say, the electric current there that the sensor is catching. So there will be some delay. And that's part of why we say to people, you know, sure, you use a sensor, but if there's a time where there may be a rapid change in blood sugars, that sugar's dropping quick or rising quick, or you're dealing with hypoglycemia, you should probably test a blood level on the glucometer as well before you make big decisions on something. So there is going to be that delay, unfortunately.
Okay. Next question. Someone has a son, Debasmita. Her son's 5 years old. He was diagnosed at the age of 3. In his typical blood glucose graph, there's always a little spike, 150 through 200 throughout the day, after a meal, morning hormones, etc. It eventually comes down within 2 hours. Are those spikes alarming?
I would not get alarmed with those spikes. We have to keep in mind that even with the best technology available, the way we're giving insulin right now is nowhere near physiologic or similar to what the body does in a person who does not have diabetes, because we're pushing this insulin into the subcutaneous space, and it takes time for that insulin to make its way to the bloodstream, have a peak effect and do its effect and work, and then shift out. So you're talking, that's where we talk like 3-4 hours of insulin action. And so that's very different than how the body does it from the beta cells directly making insulin and controlling the blood sugars. And so it's very difficult to have, that's why our target is being 70% in target 70% of the time, because there is going to be some rise, and after food is when the biggest time that happens. Now, there are ways to minimize the effect of, or the extent of rise after meals, which I'm sure you've heard, which is like making sure you give the insulin before food, maybe even doing it 10 or 15 minutes before food. Although with someone so young, it may be difficult because you don't want to give the insulin and then the child saying, I don't want to eat anymore, then you're stuck. But just in terms of if we want to get the timing better, giving the bolus for food a little earlier may help. Types of food that don't cause a big rise in blood sugar right after eating allow the insulin to kind of work and get time to become active and not allow the sugar to go up as fast. So for example, white bread versus brown wheat bread. Brown wheat bread is not going to cause as big of a rise right after food, for example. Something with pure sugar in it is going to give a bigger rise. Cornflakes is notorious. It'll just shift it up right away, even higher than 200s, even if you've given insulin before, right before you eat. So there's several factors, timing of insulin, type of food that may help with this. And it is especially true in the morning because of these hormones that are higher in the morning, growth hormone, cortisol. And that's part of the reason why a lot of people, they're more insulin resistant in the morning. So a lot of people will have like a carb ratio that gives them more insulin in the morning than the same amount of food would get insulin at another time of day. So I would say that's acceptable. That's fine. As long as we see it, we see that it comes back down. By the time insulin action is done, we're back to target range, then we've got to accept it.
Okay, great. And then her second question is a very important one that everyone is always so curious about and desperate to find the answer. Is there a permanent cure on the way? And then the second part of that question would be actually the other question that I received from someone that's on the other day. Is it worth to save our children's stem cells? Is it helpful? Two-part question.
So in terms of what's happening, we see all the studies that are coming out in search for a cure, and we're attending the conferences that talk about this as physicians who take care of kids or adults who have diabetes. And we're gradually seeing progress towards a cure. So it's going to happen, I think. It's on the way. But every step we get, we run into some new obstacle that we have to kind of face and fix. So while I do believe a cure will happen, and I'll give you a little bit of detail about where this is right now in a moment, it is a slow process. I mean, I remember when I was in training in my pediatric diabetes and endocrinology fellowship 15 years ago, we were talking about, okay, there'll be a cure within the next 5 to 7 years. And here we are 15 years later, and the cure's not here. Well, that does sound, depressing, but I will say we're much, much closer now than we were at that time. And so we are moving forward. It's just taking time, and it's longer. Now, what the cure will be, it'll have to be some form of cells placed into the body. These cells may be stem cells that become pancreas cells or beta cells in the body, or if we develop the ability to grow beta cells outside the body in like cell farms or cultures where we continuously have supply of beta cells that can be put into the body as is, not wait for it to be transformed in the body, then that'll be one step. Yes, stem cells are there. Some people have put them. In some people it has turned into beta cells that make insulin, and they had some remission for some time. Not a lot of people who get the stem cells. Not too many people get success when that's done, But the people who are, they may get remission for some time, but the problem is not getting cells in the body. The biggest problem is how do you protect those cells? Because generally everyone with what's classified as type 1 diabetes had those cells to start with. It's the process that destroyed them over time that's still there. And so you're still getting those new cells destroyed. And so the treatment and cure will need to find a way to deal with that destruction, not just putting new cells in, but dealing with that destruction, be it through medications that slow down the immune system attack on those cells without suppressing immune system in general, because we need that for protecting ourselves, or when we put these cells in the body, having them put in some form of membrane or protection that doesn't allow the immune system in. So those are two possible avenues. A third one would be if we have so many cells that we've grown that even if we put some in and they start wearing off within a few months or a year, that we put some more in. So that's kind of where the challenge is right now, is we want to make the cell placement in the body more successful by putting in beta cells directly, or making the stem cell becoming beta cell more successful, and being able to protect these cells somehow from the immune system. So that's kind of where we need to get. And that's the process that'll take, I'm still saying 5 to 7 years, but I think we're closer to the 5-7 years being true this time. Now, in terms of, well, okay, so we can use stem cells. Is this something we need to consider saving? I think personally, I think it would be worth saving stem cells. For my 2 kids, we've saved stem cells, even though it's not ready for the big time yet in terms of using stem cells to treat diabetes right now. It may be something that will be used in the future to treat diabetes or treat other conditions. And so I think it's worth it. Now, it has a cost attached, so maybe not everyone can do it. But just because of the potential of it becoming something that's used to treat many diseases, I think it's a good investment. But people will vary with their opinion on that.
Okay, thank you for that. Yes, we're always waiting, but at least in the meantime, we have technology improving that can help us get better results.
Yeah.
So next question, I believe, is in Dexcom, there's a standard deviation report. And Christine is asking, what does that mean exactly?
So standard deviation means kind of what I showed with the 2 graphs, the A1C and the kind of SMBG, where we now know that it's not just a matter of the average glucose or the average A1C. That may be great, but you may be having someone who has a lot of high numbers and low numbers, and that's not a helpful diabetes control to prevent complications if someone's getting a lot of high numbers and low numbers too. And so part of having good diabetes control means having less of that variation in numbers, that it's not going up too high too frequently or too low too frequently. And so the glucose variability, or that standard deviation number, we like that to be low. Sometimes I'll look at it and say, like, a general outlook that we kind of use is we say we like it to be 1/3 of the average, 1/3 or less of the average glucose. So if someone's got an average glucose, let's say, of 180, if that plus minus is less than 60, then that probably means the variation up and down is not very big. So that's kind of the usefulness of that is to say, okay, your average is good, but you've got a lot of variability. Just another way to assess how we're doing in terms of control.
Okay, great. Next question. Would you be able to tell us why there is always a delay in newer technology reaching the UAE? Omnipod hasn't reached the UAE yet, and the T-Slim also. Medtronic 670 hasn't reached yet, in spite of being in the market for almost 2 years. So in general, why do we, it's like, we're of course we know there's different regulations and things, but we're in the same planet and we see all these news press releases about this amazing technology. And it's like it's dangling in front of us, we're like, but we can't have it yet. So what causes those delays?
Well, sometimes it's a delay that's the company has done it themselves. So in the example of Omnipod, so Omnipod was in the US even as far back as I think 2005, if I'm not mistaken. So you're talking Omnipod's been there for 15 years. And having not, being worldwide, it took them from, let's say, starting, I don't know if it was 15 or 14 years ago, it took them till, I think, a year and a half ago, or maybe 2 years ago, to finally make their way to Europe. My understanding is, for Omnipod specifically, is that as a company, they didn't want to expand too quick and have it affect quality. Now, there's a lot of things that happen when a company wants to expand their product into other places. They need more factories, bigger factories making more supply, because they can't just say, okay, let's open up the UAE, but then keep running into shortages in supplies, Not that doesn't happen to people that are already there, but, if someone's trying to do it right, it needs to be planned correctly. So for some companies, that's kind of a reason why it slows down. So sometimes it's from the company. Other times it's a business decision. So someone's looked at maybe the Middle East or the region and said, okay, how many pumps do we think we're going to sell? Is it worth investing in opening up this market versus how much we'll sell of this product? So, there's business decisions to be made, especially like with pumps and some of these technologies that are very expensive, where unless you're able to get insurances or governments to pay for it, there'll be a big chunk of the population and families that are not going to be able to afford it. And so, okay, yeah, you've got this, expensive device and you're trying to sell it in a place that people just can't afford it. As great as it is, it won't be worth it for them as a business decision. And so that's a big part of that, those delays. Sometimes it has to do with just finding the right partner, in the country that'll help bring it on and work on selling it and working with doctors and patients and so on. There's a lot of work that goes into it. So I think that's where most of the delay happens. It's either from the company, and the big part of it is business decisions and someone deciding if it's worth it financially for people. Unfortunately, I mean, that's the business of medicine, but these big companies, I guess they want to make a profit.
Yeah. Even as a small company, I would agree with that. And I'm not in the business of bringing medical equipment here, but it has to be the right partner. And it's not even necessarily about capitalizing on it so much and making a lot of money. You just got to make money to pay the people that work for you at minimum. So there's so much that goes into it. And even though I appreciate that, I
now,
still get frustrated.
If I can add one more point to this too. If we go back, if we look at the US, maybe 15 years ago or 10 years ago, there was a time where the technology was there, pumps were there, but insurances weren't really keen and nobody forced them to pay for it. And for them some companies, insurance companies, considered it a luxury that they didn't want to pay for. Then what happened was a lot of studies came out that said, no, look, the improvement that these technologies make in terms of quality of life, but for insurance companies, more importantly, was the improvement in general health and long-term diabetes control and minimizing complications saved money over the course of life of insurance paying for the pump. So when insurance pays for someone to use a pump, they save money on the long run by minimizing complications, minimizing, renal dialysis. There's so many costs that come from the complications that it ended up being that for the insurance company, it's worth it financially to pay for this pump beyond just improving a person's quality of life. And that's still the case now. There's a lot of products that in the medical industry that may help a person's quality of life, but insurance won't pay for it. And so they initially thought of diabetes technologies like that, until we showed, no, this is, even for you, it's going to save you money on the long run. So what happened? So when you look at the UAE, so if we are saying, okay, to the insurance companies here, please invest in a pump for this person because it's going to save you money on the long run in terms of complications. Well, it's unfortunate, but that's reality. If a person's someone who's just living in this country for 2, 3, 4, 5 years, and then going back to where we all came from, our original countries where we came here, then that aspect of, investing for long-term health in the future is not there for these insurance companies. And so they may not be as interested in covering the cost as much as you would find in, other parts of the world where the whole dynamic of the population is different, where people live in a country and they're there their whole lives. So not that that's something that insurance companies will come out and say, but reality everywhere, insurance companies will look at that as they're deciding what they want to pay for.
If you have ever any of those links handy, I think there's a lot of us on the call that would like those to send as references for some companies. We have 4 minutes before the top of the hour, so I think we have time for just one more quick question. And then the other questions that come up, I'll send to Dr. Shadi after, and I'm sure he'd be happy to answer those. So any news regarding smart insulin?
In development, nothing is coming soon. We are not hearing anything about like advanced trial studies as yet. In terms of publications that say we've done this or we're doing this. So that is going to take time still.
Okay. All right. So more time. Okay. All right. I just want to thank you so much. This was so informative. I think we all learned something. Diabetes always keeps us on our toes, and we learn something new every single day with it. And I think today we all learned a lot. So thank you so much for taking time out of your day to share your knowledge and information. We really, really appreciate it. And also all your dedication to your patients that you're doing every day on a daily basis. We could not survive this thing without you.
Anytime. I really enjoy talking about this, as you can tell. So
okay, so we'll have to have you back to do a part 2 very soon.
Absolutely.
Okay, take care. Thank you, everyone. Have a good weekend. Continue to be safe, and we'll see you at the next session. Thanks. Bye.